All right, Patho, here's a quick reminder of how the anatomy and physiology of our blood vessels works so that as you start to dive into some of the conditions, atherosclerosis and ischemic stroke and stuff like that, that we have a basis that we're working on. So a quick reminder, when we're looking at the artery, it is a muscular tube, and if I can get my pointer, there we go. We can look at these three layers. So the tunica adventitia is really just connective tissue, and this helps anchor the vessel in place. So typically arteries, nerves, and veins are running together, and there'll be a connective tissue kind of connection between all of those, and then also the adjacent tissues. The tunica media, the middle layer here, is made out of smooth muscle. And particularly as we get into the smaller arteries, this becomes really important in regards to vasoconstriction and vasodilation of these blood vessels, right? The smooth muscle in the tunica media is responsible for that change. And if you look at arteries as a whole, like the big arteries like the aorta, this isn't as big a deal. Those big arteries are actually called elastic arteries, and you'll find they have smooth muscle, but they have a ton of elastic fibers, and they're more interested in absorbing like a big bolus of blood coming out of the heart with each heartbeat. But as you get into those smaller and smaller blood vessels, muscular arteries and arterioles, the smooth muscle and the power of that vasoconstriction becomes super important. We'll talk about the really important role of blood vessel diameter in things like blood pressure and perfusion of organs. Okay, the final and innermost layer is the tunica intima. Basically what we have here is a lining of endothelial cells, and in the blood vessels, that is the specialized name. This is a simple squamous epithelium, and here in blood vessels we refer to it as endothelium, but it's epithelium, right? The basement membrane, again, is connective tissue that just always underlies. So the thing to keep in mind with these endothelial cells is that they are quite active. And so this slide is showing us a bunch of different substances that those endothelial cells can release, and the roles those have in things like vasoconstriction, vasodilation, clotting. We were already talking about some of these, right? Von Willebrand factor, when there's damage to the endothelium, that von Willebrand factor becomes exposed, and that's going to do things like activate clotting. Again, keeping that in mind in some of these disease states, that intrinsic pathway for clotting becomes particularly important because things like hypertension, high blood pressure, can cause enough damage to endothelial cells to trigger things like von Willebrand factor and clotting. Okay, so the flow of blood, if you recall from anatomy, blood flow is equal to the change in pressures over resistance, right? There's an actual formula. I don't know that I have the power. I could do it. I can do this. Blood flow is proportional to the change, delta, right? The change in pressure. So pressure 1 minus pressure 2, change in pressure over the resistance. Okay, so what we're going to find, right, blood wants to flow from areas of high pressure to lower pressure. It's constantly just moving in that direction. That's what it wants to do. So the bigger the change in pressure, right, the more we can get blood flow. But that change in pressure also always has to be able to overcome resistance. So resistance can be caused by things like the viscosity of the blood or by the resistance of the vessel, right? So if it's constricted, if we have a smaller hole to fit through, that would increase the resistance. And then also any turbulence. So here we go, let's look at this. So things that affect vascular resistance. The length of the vessel it increases the surface area. And what we find with blood flow is that blood exhibits what we call laminar flow, which means along the edge of the vessel, the blood is experiencing friction. So it slows down there, but then the blood cells just inside of that move a little faster, and eventually right at the center of the vessel, that's where blood is actually moving the fastest with the least kind of drag on it. And so that sets up the situation where the length of the vessel actually does make a difference, right? If you have a vessel twice as long, you get half the blood flow, right? We get more resistance. And you don't necessarily get half the flow, but the pressure needs to overcome that increased resistance. Now, blood vessel length is pretty much set, right? So we're not making big changes there. So what we're more interested in, right, is probably down here where we're looking at the diameter of the blood vessel. So notice what happens here. We go from a 2 centimeter wide vessel to a 1 centimeter wide. Now, length, when we doubled the length, we halved the flow. Here, when we cut the diameter in half, we increase the resistance 16-fold, right? So this by far is the biggest component of resistance to blood flow, the vessel diameter. So vasoconstriction, vasodilation is super important. And then we get turbulence. So any time there's something like a plaque on a vessel wall, notice what happens. We interrupt that really nice laminar flow. The blood starts kind of being in turmoil, and it doesn't flow nice and easy. That's going to add to resistance. The heart is going to have to push harder to overcome things like vasoconstriction, like turbulence, and viscosity, right? There is some turbulence naturally. Valves create turbulence, big turns to get into blood vessels, there's turbulence, but you don't necessarily want to add to that by having something like this plaque. Okay, is this coming back, hopefully? Okay, and then blood pressure. So blood pressure, hopefully we recall, like when we measure this with a sphygmomanometer, we're measuring systolic over diastolic, right? So normal is 120 over 80. We're probably pretty familiar with that. But remember what systolic and diastolic mean. Systolic is the pressure when the heart is actually contracting, right? So when there is force behind it, right? What is the the pressure in that artery? And then diastolic is when that heart is relaxed, right? And so we're not actually forcing any blood here. Okay, so then let's take a look at blood pressure this way. So systolic, again, when the heart is contracting, diastolic when the heart is at rest. And typically when you're taking blood pressure, you'd be in like a muscular artery, like a brachial artery. So a couple really important things that we see here, right? Mean arterial pressure, okay, is this value they're showing with a red line here. And mean arterial pressure is actually something that you can calculate. Granted, if you're working in a hospital, right, your machine is going to do this for you. But mean arterial pressure, basically what you do is you take the diastolic blood pressure and then you add the pulse pressure, which is systolic minus diastolic. I'll just do that. Pulse pressure is systolic minus diastolic, and you divide this by 3. So mean arterial pressure is the diastolic blood pressure plus pulse pressure divided by 3. Now, more important than remembering the calculation is understanding what it means. Mean arterial pressure tells you about the perfusion of organs, because remember, blood wants to flow from a place where there's higher pressure to places where there's lower pressure. And you need pressure to overcome resistance. And so, right, so you want that blood to flow into the capillaries because that's where all the gas exchange takes place. And so you need a high enough mean arterial pressure to continue to perfuse organs, okay? So again, when you think about blood pressure and this idea that flow, you need resistance to overcome the change in pressures. What you're going to find is that any increase in factors that cause resistance, right, turbulence, viscosity, vasoconstriction, are just going to mean that we're going to make the heart produce higher pressures to maintain this mean arterial pressure, right, to maintain blood flow to our organs. And so we'll look at that in things like hypertension. Okay, the other thing to remember when we're talking about blood flow, and this will be important in a lot of diseases, are the different receptors and hormones involved in the maintenance of blood pressure. So recall that you have baroreceptors. These are going to be in the carotid and aortic sinus. These sense a drop in blood pressure and automatically trigger the sympathetic nervous system to increase heart rate and cause vasoconstriction. Now, this vasoconstriction isn't everywhere. Essentially, here what we're getting is a fight or flight response. And so we're going to be trying to send this blood to important organs and maybe not to the viscera, maybe not to the skin surface, that sort of thing. The other thing that's going to happen at the same time, right, is kidneys can sense that drop in blood pressure, and they sense this in the form of hypoxia, right? So not necessarily, they don't have a pressure receptor, but they're sensing that they're not getting enough oxygen, therefore probably not enough blood flow. And we kick off that whole renin, angiotensin, aldosterone system, trying to increase blood volume and blood pressure. We can also sense this at the posterior pituitary, release antidiuretic hormone, which again increases blood pressure, blood volume, and therefore blood pressure, right? So all three of these are working together to bring blood pressure up enough to get perfusion of our organs. The hormone that works opposite of these is going to be atrial natriuretic peptide and brain natriuretic peptide. Those are both released from the heart. When the heart is overstretching because there's too much blood pressure or too much blood volume, that hormone is basically going to be an antagonist to things like aldosterone and ADH and really tell the kidney to flush the fluids and decrease that pressure. So, and there's a little review of cardiac output if you need that. Oh, that's a different way to look at it, right? Typically, we talk about cardiac output being heart rate times stroke volume, and this is interesting. This is thinking about blood pressure over total peripheral resistance or peripheral vascular resistance. And so if blood pressure increases, cardiac output increases, etc. Okay, so what we're going to jump into when you get into these diseases, we're going to start by looking maybe at some of different things that might be in blood and then how that's going to affect vessels. I'm going to leave it there. We'll pick up in class.